A very good morning and welcome to the live stream of the first session, session 5 of today, Amblyopia Free Papers. Today we start off very welcome to everybody here in the church and very welcome everybody joining us from the live stream. We start with the first speaker of the day, that is Sjoukje Loudon. Sjoukje Loudon is famous for the compliance studies on amblyopia, and today she will talk about her newest research, randomized controlled trial comparing dichoptic games with occlusion therapy for amblyopia.
Thank you. Good morning, ladies and gentlemen. Thank you very much. Maybe a bit out of the comfort zone of screening, we are now at the other end of the spectrum dealing with treatment for amblyopia and specifically comparing two treatments for amblyopia. We did a randomized controlled trial comparing dichoptic action video games using the VR goggles with the standard occlusion patch for amblyopia. And I'm standing here, I was the PI, but the bulk of the work was done by Aveen Kadam, she's my PhD student, and Emily Tan, she's our research orthoptist. So they did most of the work, I'm just here presenting it. We have no financial interests, very many sponsors who we also like to thank. Just a brief background, amblyopia is the most common cause of monocular visual impairment in children and defined by the presence of an early amblyogenic factor, either an anisometropia for which we give glasses or strabismus. We can have a combined cause of amblyopia or deprivation amblyopia by either ptosis or unilateral cataract. As you've heard yesterday, we have a very extensive screening program in the Netherlands, and the eyes are screened from birth and visual acuity is measured at the age of 4 years before the children go to school. And the standard treatment in the Netherlands is still the eye patch, patching the better eye for several hours per day. It's a very effective treatment that has been proven. However, its success is hampered by poor levels of compliance, ranging from parents doing absolutely nothing to parents doing about 60%. So mean compliance with occlusion therapy is about 60%. We did, as Jan Roelof said, we did all these studies with the occlusion dose monitor, which I will explain a little bit later how it works. And we looked at ways if we could improve compliance by not necessarily educating the parents, but by developing an educational cartoon story which was aimed at the child, explaining the necessity of the eye patch to the child. And this improved compliance significantly. That was my study, and Angela Cham did a follow-up study, and she looked at the when giving the educational cartoon story, specifically in low socioeconomic areas, this improved the rate of visual acuity improvement. But still, especially from North America and Canada, there came these studies saying, no, the patch is boring, we need more interactive. It's a binocular problem. Amblyopia is a binocular problem, and treatment needs to be addressed binocularly. So in came the VR goggles and the games, the Tetris games. I'm sure you're all aware of these games. And all the published work said the treatment works. Mean improvement is about 1.5 to 2 lines. However, the main issue again is that they didn't measure compliance electronically, so there was no way of knowing that the parents actually did what they were supposed to do, thereby making a valid comparison between these two treatments very difficult. So we set up this study in 2016 with a purpose to make a valid comparison between the effect of patching therapy and the dichoptic action video game in children with amblyopia. And the primary outcome was visual acuity improvement in logMAR per time period with electronic monitoring of compliance in both groups. So how was this done? We recruited all newly diagnosed amblyopic children in four clinics who were aged 4 to 12 years old. We did a cutoff at 4 years old because we knew from the literature that the younger children wouldn't be able to play the game, so we had a cutoff at 4 years. And it's also known that if the angle of strabismus is larger than 30 prism diopters, they would not be able to fuse the two images. So they all had a 16-week refractive adaptation period if that was necessary. We looked at compliance with we looked at compliance with spectacle wearing. If amblyopia still persisted after 16 weeks, usually after 16 weeks, amblyopia had improved to 0.1 logMAR line difference, and if that was the case, they would be referred back to their orthoptist. If amblyopia was still there, they were randomized to either the patching group or the gaming group. And if you were randomized to the patching group, you would have to patch your child for 2 hours per day. And we looked at compliance with this occlusion dose monitor. It measures the temperature difference between its front and its back every 2 minutes. And it stores it in its memory, and it has a memory of about a week. So after a week, it was collected and the data was read out, and we could see exactly when and for how long the patch or the glasses were worn. If you had been randomized to the gaming group, you had to come into the clinic. So this was in the clinic for 1 hour a week for 24 weeks, and the parents needed to come in every week for 1 hour of gaming. And every 6 weeks we measured visual acuity. That was done by Emily Tan, the research orthoptist, stereo acuity and contrast sensitivity. And what we also did is that we were interested in the experiences of the parents and the children to see if they had a preference for either treatment. So this is the setup for the game therapy. It's based on the principles by Dennis Levi. Dennis Levi's game was a little bit aggressive, we thought, for the children. So we had a company in Haarlem who made it more child-friendly. It's a snowman, so the snowman appears, and the child is instructed to throw snowballs at the snowman for extra points. It's in a VR headset, and the VR headset is big enough for the child to wear its own glasses underneath. This is my son. And we took him to the clinic, and you can see the setup. So this is the laptop here in the distance, and you can see on the screen of the laptop exactly what the child sees in the VR headset. Because what needs to be done is, you can see this is what the child sees in the headset. The left eye is the fellow eye in this case, and this is presented to the left eye. This is presented to the right eye, which in this case is the amblyopic eye. And what needs to be done is the contrast and the luminance of the fellow eye needs to be reduced based on what the child sees in the VR goggle. So this is something done subjectively, which makes it difficult for the younger children to be able to comprehend what we ask them to do. The second task the child needs to do is the alignment task. So this half cross is presented to the left eye, this half cross to the right eye, and the child needs to be able to fuse the two images. So they are asked, do you perceive this cross, yes or no? And these two tasks are done every time the child comes into the clinic before they start their treatment. That's what makes it complicated for them. So I'm going to go over to the results now. So we recruited children for 2.5 years, and we were able to collect 100. We discussed participation with 89, and 29 parents refused. They refused to participate mainly because they thought the game would be too time-consuming. They didn't want to come into the clinic every week for 1 hour. They had other children to attend to, and they thought it would be too much of a burden. So 69 were eligible. They entered the refractive adaptation period, and almost a third of them did not have amblyopia after treatment with the glasses alone. So we randomized 35 children, 17 to the gaming group and 18 to the patching group. And even during treatment, 10 children dropped out of the gaming group, and 3 children dropped out of the patching group. So in the end, we had 22 children who completed the study. So we actually wrote a paper about these hurdles that we encountered during the treatment, because everybody is very enthusiastic, and it's nice to be able to offer them something else than the patch. Oh, a gaming therapy, children love to game. They do love to game, but not when they're told to game. So we looked at these problems, because it's not something new. People already know about these problems, but nobody really discusses them. So we thought it would be imperative to write a manuscript about them. And we just got it published last month. And the main problem was that they lost interest in the game. And you can say, oh, well, give them a new game, but each game was about 12,000 euros alone to develop the game based on these principles. So it's not something insurance companies would be willing to pay if you compare it to the price of a patch. So they lost interest in the game. They didn't want to come back to the clinic. Parents had difficulties getting them back. And then came the excuses. No, he has a test tomorrow, he can't come in. No, child number 2 needs to go to the ballet. All kind of excuses came. The younger children had difficulties with the game settings. We have a nice video of a 4-year-old girl who's just staring into these goggles and waving her hands, and she has no idea really what to do with the goggles on. The equipment was sometimes a little bit too large, and I said, so this is with the game settings, making the cross and doing the luminance and the contrast setting, and difficulties comprehending the game. Even, just throwing snowballs was difficult for them. And then, of course, there were because the VR set gets warm, the glasses get foggy, and the children don't necessarily notice them getting foggy, and this would lead to frequent breaks to be able to check if the glasses were still okay. So back to our patient characteristics, we had 35 children, equal boys and girls, and the children in the patching group were a little bit younger than the children in the gaming group. This was not significant. Most of them were anisymmetropic amblyopes, as expected because of our inclusion criteria. Visual acuity was about equal, and compliance with spectacle wear was about 76%, and compliance with patching was 81% with a large range. And compliance with the gaming, well, that was 100% because they had to come into the clinic. Now, if you look at visual acuity improvement, the green line is the patching group, the purple line is the gaming group, and on the y-axis is visual acuity. This is in the amblyopic eye in Logmar, and on the x-axis is the time in weeks. And you can see visual acuity improves in both groups significantly, but there's no significant difference at the end of the therapy between both groups. What you can see is there's a large, these arrow bars are the 95% confidence interval. For the gaming group, they're about twice or triple the size than for the patching group. And even if you correct for age and diagnosis, the significant difference remained the same. So conclusion, dichoptic action video game using the VR goggles and patching, they both improve visual acuity. In children, there was no significant difference between the groups. However, we had an enormous amount of dropouts in the gaming group, not something we actually anticipated when we started the study, mainly because of compliance issues. So patching is hampered by compliance, this is hampered by compliance, but different kind of compliance issues. It was time consuming, so when you have a patch, you can put the patch on the child and you can go do your shopping. When you do these VR games, you need to be in the house, monitor if your child is doing this game, yes or no. Jonathan Holmes did the iPad study. He gave the iPads to the parents to do at home, and the compliance was so low, he wasn't able to do a reliable statistical analysis on the effect of both treatment groups. Logistical challenge, that was also with the patching, and especially the younger children. So we didn't really have a child younger than 5.5 who was able to do the game. They just didn't understand how to do it. And there's also the cost issue. So we had a research orthoptist who came into the clinic to sit next to the children, do this. So for practical implications, who's going to apply this treatment? And are you going to give the VR goggles with the parents to the kids at home, to do at home? We are still doing the semi-structured interviews to the parents and the children. And what's just something that was interesting, I thought at least, was that the parents who did complete the gaming therapy, they said they preferred to do the gaming because then they were not responsible for applying this therapy to their child. It was somebody else doing the therapy. So that's why they preferred the gaming. Well, we have a big research team. My colleagues in Rotterdam and the School of Utrecht, the recruiting clinics, and Professor Levi for sending us his game. Thank you very much for your attention, and if there are any questions. It's a bit out of the screening range, so maybe...
Yes, there's a question.
That's very interesting, and also I was a bit surprised that 1 week, only do it 1 week, the gaming, could be sufficient to train the eyes and the brain. So I wondered, is that because of practical reasons that you have 1 week chosen, or is there a background that it really can improve only playing this game once a week?
Yeah, it's a good point. We did 1 hour per week for 24 weeks because the literature said that 1 hour of game, so 24 hours of gaming, actually 17 hours of gaming is enough to improve visual acuity 1.7 lines. So that's why we compared this total amount total amounts because it's the cumulative, it's not per day, it's the cumulative amount of treatment received. And when we actually started this study, most of the literature was still in adults, not in children. There.
Hi, did you calculate the attention to treat versus the intention to treat and compare that into the two groups?
Yeah,
which is a classical epidemiological way of doing it.
Yeah, no, we're still working on the graph I showed you. That was only a couple of weeks ago. So we're still in the process of looking at that because there was a large range of compliance as well. So we need to correct for compliance, etc. as well.
I have another question from the chat. It's from Maria Fronius. She's not in the session right now, but she's in the chat. What about compliance with spectacle wearing, and was it age dependent?
The compliance with spectacle wearing was not age dependent. Wat was the eerste?
What was compliance with spectacle wearing?
Yeah, it was actually lower than with the patch, which we thought was a bit surprising. We're looking into that as well, because we have children who wore their glasses very well, because if you didn't wear the glasses, you were not randomized. It was very strict. It was kind of it's not a wild type study.
But was it in any way age dependent? Did the younger children do better than the older?
No.
Any other questions for Sjoukje? Yes? There, Tessa?
Have you suggested to continue this game at home by mobile phone, because I very often suggest to parents to continue this training at home.
Yeah, but
During patching, during time of patching.
no, because we wanted to see pure the effect of patch. Yeah, so that's if you want to look at, if you look at the reviews, there are lots of reviews now which have been published, comparing patching with glasses, comparing patching with the dioptic video game. But if you look at the literature closely, it's either patching and dioptic action video game with glasses. So it's not only patching with only dioptic video gaming, and that was the purpose of this study, to compare just the effect of that one versus that one, not patching and then so 1 hour of patching and then 1 hour of gaming. It was pure research.
Okay, thank you. Thank you. We move on to the next talk. It will be me.
Yeah, that would be you. So Jan-Olof Polling is our orthoptist doing his PhD in many things amongst myopia, but we also have a very big study in Rotterdam, the Generation R study, and we've looked at ophthalmological findings in this study population.
Yeah, thank you for the invitation. Really nice of the organizers to invite me. I will explain something about what happens after screening. So I will explain what amblyopia is left after vision screening in the Generation R study. I have no conflict of interest to declare. So the gold standard for vision screening is still for detecting amblyopia and refractive error is still visual acuity, and amblyopia is the primary target for vision screening in young children. We screened at the age of 6, or it was not a screening, it was a study, and most pediatric ophthalmic eye problems would have been then demonstrated by the age of 6. Good to know is that you would see that in the prevalence of amblyopia in screened populations is much lower than in unscreened populations, and we would like to investigate if this was the case in the Rotterdam children. So our research question is to report on the prevalence of these ophthalmological findings in a pre-vision screened and treated cohort of 6-year-old children in the Netherlands, and we wanted to know the medical reasons for low visual acuity and also the impact of the diagnosis on the visual acuity. And we used the Generation R cohort, and that is a Rotterdam-based cohort of Rotterdam children being born between 2002 and 2006, and it's nearly 10,000 children being born in this cohort, and they're all in the study. And we investigated them at the age of 6, not only 6, but also 9 and 13, and they're showing up for their 17-year investigations right now. So we're further down in the study. So getting the data was really difficult. So we asked if there was a contact with an eye specialist at the age of 2, 6, 12, 18, 24, 30, 36, and 48 months. And then again at the research center at the age of 6, so we knew that whether there was a contact with an ophthalmologist or orthoptist or optometrist or with an eye specialist. Then we performed the visual acuity at the research center with the LIA symbols, we referred all children having a visual acuity of worse than 0.1 logmar, then there was further workup. And so there are two groups. There are the newly detected, so the people who had a visual acuity worse than 0.1 logmar, and there was the persons who had already been in contact with an eye specialist. So we could compare these groups and see the differences between these groups. And for the children who were known with an ophthalmologist or orthoptist, we obtained the medical charge and to see the history of the child. So we defined amblyopia as a logMAR visual acuity of 0.3 or worse in the amblyopic eye. There had to be an intraocular difference of 2 lines or more, and there had to be an amblyogenic factor. So all these 3 measures were entered into the database, and then we could see whether the child was really amblyopic or not. And we code the strabismus according to a national system, and it is comparable with international systems going around. And that was done by the orthoptist who send in their medical charge. We used the guidelines that are available. So these are the APOS criteria for amblyogenic factors. You probably all know them. And this is the first slide of the results of the study. So we called all these 10,000 children, or nearly 10,000 children, and almost 7,000 children participated in the exam. We had a visual acuity measurement in almost all children, or 96%, almost 96% of the children participated in this exam. We had 323 children being referred because of a not good visual acuity, and already 8.5% of the children received eye care. And then in the children who did not have a visual acuity measurement, and that was because of the failing of the equipment or anything, or there was no time left for this exam, in those kids there were also some referred children, but also some who already received eye care, but that was not statistically different than the other group. So the population looked as following. We had children coming in just over 6 years old, and half of them were girls. There were more eye exams or more eye care used by children with a premature or a lower birth length, and also a low birth weight. So these were significant findings, and also people with a lower socio-economic status used more eye care than the other, so low income and less income and low education were associated with more eye care. Then looking at visual acuity, you could see here on the right in blue the visual acuity in the better eye. Both eyes had a visual acuity. This is a healthy cohort, right? So you wouldn't expect any problems with eyesight. So the median visual acuity in both eyes was good, and for the better eye, it was the interquartile range was 0, and in the interquartile range in the other eye was 0.1, so slightly lower, but not very different from each other. Interesting are these children, these 55 children who had a visual acuity of lower or worse than 0.3 in the better eye. And these kids, more than half of them already received eye care, so they were in the picture of the eye care providers. More than a third had amblyogenic factors, and the rest was mainly refractive error was the cause for that thing. And also what was notable is that 80% performed a better test in retesting clinic, so that so the orthoptist just squeezes a little harder to get a better visual acuity. So this is the distribution of strabismus subtypes. We also asked the orthoptist to code them. So this is what you mainly see in your orthoptic clinic. So nearly half of the, or more than half of the population or your strabismus types is accommodative esotropia, either partial or fully. And then intermittent exotropia is also 1 in 5. And then you have the special forms, which includes the infantile esotropia, but your Duanes and your Browns and all kinds of things. Then ESO, EXO, other, and also the primary microesotropia is also a proportion that should not be missed. So we looked at visual acuity in relation to strabismus subtypes. And what you see here on the left is again in the best eye, in the better eye, and on the right you see the amblyopic eye. So the red is the amblyopic eye, and you see that certain diagnoses tend to have a worse visual acuity, and especially the primary microesotropia still has on average a significant amblyopia, but what also could be seen is in the better eye. So in the better eye, and this is not what we see in clinic, that the non-strabismic had a very good visual acuity, but also the better eye in strabismus has a suboptimal visual acuity. And that is a significant finding that has been described before. So amblyopia in relation to what we have found in the different groups. So if we have this definition of amblyopia, we found in total still 31 with a residual amblyopia left. Of them, 26 had already received eye care, and the newly detected were 5. So we still had 5 undetected cases of amblyopia. In relation to the strabismus subtypes, I already said that half of them still had amblyopia, so half of the primary microesotropia still had amblyopia. Constant esotropia, the fully accommodative, they don't have as much amblyopia. And 1 in 3 partial accommodative esotropia also has this. So the equivalent of this worse than 0.3 logMAR was 84 out of the newly detected children. 2 were caused by strabismus amblyopia, 3 with a subnormal visual acuity without any eye problems, and 79 were because of refractive error. So this truly significant amblyopia was only in 2 persons. And 74 again had a better visual acuity when they were tested by the orthoptists. So it is a healthy cohort. So we found a prevalence of strabismus of 1.7, which is slightly low, and that is because it is a healthy cohort. You don't go to a screening if you have a already diagnosed strabismus probably, although strabismus was not the outcome of the study. They did a general examination. The literature prevalence of residual amblyopia in screened population is 1%, and we found 0.5%. No population-based literature on many of the eye conditions that we saw, and also in strabismus subtypes. And we had a 2-step referral with cycloplegic refraction, so we didn't measure all the children. That is a downside from this study. So in conclusion, the median visual acuity in these kids is really good. 51 children presented with a low visual acuity, and 1 in 5 explained by uncorrected refractive errors, and more than a third was explained by amblyopia. Prevalence of strabismus was 1.7, and accommodative esotropia represents half of the cases of strabismus. And the visual acuity in the better eye of strabismus is reduced, and the prevalence of residual amblyopia is 0.5%. Mainly the manifest esotropes, those are at risk with a residual amblyopia, and your constant esotropias, your micro and your partial accommodative esotropia should be the primary focus on your amblyopia treatment. Thank you for your attention.
Are there any questions?
I have a lot of questions.
Good.
Yeah, Roelof, fantastic, this enormous study where you will receive your PhD on the 22nd of September. It's been a very thorough, dedicated work. My first question is 0.46% residual amblyopia. That has been described in Swedish studies. So in Sweden they say it's 0.5, whereas we found 0.85 in Amsterdam in the Ramsey study. But the question is, there is also decreased visual acuity because of uncorrected refractive error.
Yes.
And then it's the question whether you would not still consider that as minor amblyopia. So,
Yeah,
so that would increase the 0.46.
Yeah, that's a good point. So that's a difficult question to answer with this database, because we would have then have to look into the persons who have. Then you must be sure that these persons also have a amblyogenic factor. That is definitely so. I have to distinguish between the persons who have amblyogenic factor and just a standalone refractive error. Yeah. And that is important. That's a good point to take home, and I will look in the database again to see if I can detect these people. But that is a good point. However, I also would like to make a remark that the Ramsey study used a different cutoff point for amblyopia. Yeah. So then these studies are difficult to compare. There was this Lancet review by Hugo Rai explaining the different criteria, and we took the one that was used most.
And then secondly, in the PhD by Freya Sloot on the 8th of September, the article, which is already online with Acta Ophthalmologica, but not being assigned to an issue, not published on paper, it is clear that the diagnosis of the cause of amblyopia is different in the same child at different ages. Yeah. So the criteria for differentiating between refractive amblyopia and strabismus amblyopia do not change, but the degree of anisometropia decreases slightly over time, so that you get a shift in cause of amblyopia. So very critical in your listing of causes of amblyopia is the age at which the diagnosis, the cause of amblyopia was made. So at what age did the orthoptist decide what kind of amblyopia this was?
Yeah, well, the generation R cohort is a prospective study, but this is a retrospective analysis. So that is difficult to obtain. We only asked for these information after the age of 6. Yeah. So we then go back to the orthoptist and to see what's the first eye contact. So we have slightly, but that is probably not too reliable data that we have on that. So unfortunately, that was also very good. points. Thank you.
Okay, I think we need to move on to the next speaker.
Yes.
If there are no many questions. Mr. Dongsheng Yang from China. Yijinan, yeah. Manit? Not her? Who will talk to us about a new binocular therapy for refractive amblyopia.
Hello, everyone. Many thanks to Dr. Simmons for the opportunity. My name is Dongsheng Yang. I am a pediatric ophthalmologist, work in Jinan Puri Eye Hospital, belongs to Bright Eye Hospital Group. In the next few minutes, I'm going to show you a new method for refractory amblyopia treatment. Introduction. Placing a neutral density filter in front of a better eye reduces the luminance, but doesn't change the contrast a lot for that eye. So it is argued that if the variant neutral density filters works for monocular amblyopia or not. There are proposals to using the neutral density filter for amblyopia treatment from laboratory work, but no clinical report available. However, we placed neutral density filters in front of a dominated eye to balance the visual acuity of each eye and obtain significant visual improvement in patients who have failed in atropine and patching treatment. We investigated the effect of neutral density filter on amblyopia because we believe that this method is much more cost-effective than computer-based binocular therapies and bandage film. A Snellen chart was used to test the effect of a neutral density filter and to select a specific neutral density filter for an individual patient. The luminance of the Snellen chart was measured using the luminance meter. With the light on, the luminance of white background and the black letter of the chart was measured and listed here. The contrast of the light chart was 97%, which was calculated using this formula. To simulate a daily life visual condition, we turned off the light of the chart, the luminance of white background, and the black letter of chart was such and such respectively. The contrast of the chart was 95%. This light-off condition was used to select a neutral density filter. To control the room brightness, dark curtain was used to block light from outside, and the ceiling fluorescent lamps was used to light the room. The luminance of the lamp was measured and shown here. Effects of neutral density filter on luminance and contrast of a Snellen chart and the light on and the light off condition was tested. We placed the neutral density filter in front of a luminance meter and measured the luminance of the dark letter and the white area of the Snellen chart. As you can see here, the neutral density filter, when it's not on, here is the luminance and the contrast. And when the light off, the luminance and the contrast. As the numbers goes up, the contrast, the luminance and the contrast, in each condition dropped dramatically. Here is the pictures for those tests. As you can see here is the contrast. As the neutral density number goes up, actually the contrast also drop. But on the luminance, when the neutral density filter goes up, the light off condition, so the luminance drop dramatically. 4 patients with refractory amblyopia who had failed to respond to occlusion and atropine penalization therapy was treated using the neutral density filter. We placing a neutral density filter in front of the dominating eye and adjusted its density so that the visual acuity in the dominant eye was 1 line lower than in the amblyopia eye. The selected neutral density filter was attached to the glasses. Subject wore the glasses during their waking time and as long as possible during their daily activity. Intervals for follow-up visit was 4 to 6 weeks. Neutral density was adjusted to be shallower when the visual acuity of the amblyopia eye improved more than 2 lines. It was showing that the best corrected visual acuity of the amblyopic eyes was significantly improved for more than 4 lines on average in 16 weeks. Stereopsis was improved also. Case number 1, who is a 46-year-old man. His vision improved from 2033 to 2025 in 10 weeks. Actually, this patient had exotropia that was corrected. Then the treatment started after the correction. Case number 2, a 36-year-old woman. The visual acuity in the left eye was lower, it's 2033, and improved to 2016 within 10 weeks. And also stereo acuity improved from 60 second of arc to 40 second of arc. Please pay attention to the age of these 2 cases. One is 46, this one is 36. They are quite unusually old for the treatment of the amblyopia. Case number 3, a 9-year-old male student. The visual acuity was low in both eyes, as you can see here. And after 16 weeks, her stereo acuity was improved from 100 minutes a second of arc to 40 second of arc. Interestingly, not only the amblyopia eye improved vision, but also the eye with neutral density filter also improved, which is very interesting. Case number 4, a 16-year-old female student. Her right vision was 2032, as you can see here, and after 16 weeks, her vision was improved to 2020. Also, his stereo acuity was improved from 200 second of arc to 40 second of arc. Conclusions. Wearing a neutral density filter in front of the dominant eye improves vision and stereopsis for refractory amblyopia. It indicates that neutral density filter wearing on dominant eye may be an alternative way for amblyopia treatment. It is important to turn off the light when neutral density filter was selected. What's the mechanism involved here? Is this because the binocular cells was turned on? Thank you for your attention.